Next speaker, Dr. RAM RAJ GOPALAN, needs no introduction. He is the professor and head of Department of Clinical Services and Critical Care Medicine at Sri Ramchandra Institute of Higher Education and Research at Porur, Chennai. He has been the past president of ISCCM, and I have been seeing him last 20 years. He has been still very active and, as usual, the brain of ISCCM, I would say. He will be talking on, is the paradigm shift to mechanical power and the esophageal pressure clinically effective? Over to you, Dr. Ram RAJ GOPALAN.
Thank you. It's a great privilege to come back here to Hyderabad to give a talk over here. I was very nice of the organizers to let me do whatever I wanted to talk. They let me pick on the topics. So I better be good in what I'm going to say right now. I promise you I will not be as articulate as my predecessor. Suresh is very good, so good in terms of his gift of the gab that he can write his slides and people will still be very happy about it. I have to, on the other hand, rely on the quality of my graphics if I'm going to make any kind of a statement at all. So I apologize if I'm not very clear. Look at my graphs. Okay, power. All right, let's just start with this. The issue, the topic that I was asked is my mechanical power and esophageal pressure appropriate for use today? And that's going to be the approach that I'm going to effectively take. I think all of us know that the improvement in ARDS survival over many decades has been primarily related to the fact that we reduced tidal volumes at one point in time. And I think after that, virtually nothing that we have done has dramatically improved in terms of the outcomes that we've seen in ARDS. So broadly, when you look at it, what we are trying to do is try and improve on this. And the approach that we have always taken is, since the two things that have always been very effective, which is the reduction in your tidal volume and a focus on your pressures and trying to keep the pressures reasonably low is appropriate. We've always built it on what we would consider a classic elastic model. Very simplistically, it's a rubber band that is being pulled apart, and the kind of deformity that you create is going to be completely dependent on the kind of pressures that you exert on the rubber band and the amount of change that you're going to induce within the rubber band, what we call as your stress and your strain, which in a clinical situation actually translates into the same thing, the pressure and the volumes that you are effectively giving to the lung. So a very simplistic kind of approach to how we can create lung injury, okay, and that is the major reason that we believe that we're not having an improvement in outcome, is we are creating lung injury. And the approach to this will be to say simply, look at an integral area between the pressure and the volume, and that is effectively what we were doing for a very long time. So we draw these very complex pressure volume curves and say the larger the area, the more pressure you exert and the more volume that you deliver, the more damage you're going to create. Okay, and the use of these pressure volume curves were reasonably logical, but we were missing on something very, very clearly over here. And that was the issue related to the fact that lungs are not just rubber bands. Lungs are rubber bands which float in a viscous fluid. And you need to deform this fluid also. And when you are going to be deforming this fluid, the physical rules are a little different. So very clearly we know there are lots of these glycosaminoglycans and proteoglycans in the interstices, and they behave more like liquids than they behave like rubber bands that can be stretched. So effectively, when you look at it, we need to understand that this viscosity element also has to be brought into the picture if we're going to look at lung injury in the first place. And very clearly, when you're deforming a fluid, what is important in this is not just the proportional stress that you will create, when you have a specific strain, or that when you lengthen the fiber, the development of pressure is not just linearly related, but it is clearly related to what we call as the shearing forces that are present between the layers of the fluid. And this can actually genuinely exaggerate the amount of stress that you can create on the lung. And what is equally important about this is, this shear force is completely dependent on time. Whereas stretching of a rubber band, it actually doesn't matter. What you need to know is how much you're pulling it apart and what kind of pressure you're exerting on it. Okay. In this, on the other hand, you definitely need to know the rate at which you are producing it. And as a consequence, a new component comes in. That is, in the previous models, we looked only at pressure volume changes. We didn't look at the rate at which that change occurs. And that is going to be extremely important to me. The eye-opening animal experiment that I used to love to show is this one which they did on pigs. where effectively they gave these pigs very high levels of airway pressures. That is, they pushed it to a strain of almost 2.5 times what is normal. Okay, and ultimately what they saw was when you are creating this kind of a strain, which is, okay, you could do it in one of two ways. You could do it either by raising your basal pressures or by increasing your driving pressures alone. Okay, and if they clearly see there's a big difference on the one side. If you raise the strain from 0 to the highest level rapidly, the amount of lung injury that you created was significantly more than when you raise the strain by giving a large amount of PEEP, which is a static pressure, and then using a small tidal volume on top of that. And effectively, the amount of injury was clearly related to the existence of what we would call a dynamic strain. Here again, it brings the very important issue of time into the circumstance, into the entire picture. So, if you're looking at the determination of a change in your energy that you're delivering to the lung, which is basically the integrated area that you're talking, as a function of time, we need to look at what we call as power. Power effectively is the change in your, in your lung work or your energy that you're transmitting to the lung over time. And that is basically what we do. In power, effectively, what we are looking at is these varying components of your mechanical energy that you're giving, and you're definitely looking at the fact over time. The higher you use, the higher respiratory rate you use, the more likely you're going to create a problem. So this is the broad principle, okay, that we need to understand, and the importance of viscosity that comes into determining how the injury will occur. So with this as the problem, how did we derive mechanical power? Ideally, if you all can draw pressure volume loops, okay, and you can look at the area under the curve, we can all be very happy about it. But it's frankly impractical. It's not going to happen. So ultimately, Gattinoni and his colleagues, and probably a whole bunch of other people, have derived what are called, equations that can translate this graphical understanding of your power into some kind of a mathematical value that you can calculate and derive. Unfortunately, what happens with this is there are a whole bunch of equations that completely depend on the kind of conditions that you're going to subject the patient to the ventilator support. It is very different for pressure control, it is very different for volume control. And the kind of formulas that are used are highly sophisticated in some situations. Like for instance, when you're using pressure control, should you adjust for the rate of rise of your pressure, or could you just use this as an average rise in pressure? And if you really look at most of these studies, however you derive your pressure, your power, they seem reasonably identical. So it really doesn't matter which method you're going to use, but if you're going to use a pressure control ventilation, you better assess it with one of the formulas related to pressure control. If you're going to use the volume control, my strong recommendation is use the Gattinoni equation. So up to this point in time, we have understood what power is. We recognize that it is easy for us to, not easy, okay, it'll be nice if all these algorithms are built into the ventilator, it can easily be done. And ultimately it spits out number of power on you on a regular basis. It may be something that you can easily get. Okay, now we need to ask ourselves a question of how is this power related to outcomes in all our patients? And as far as that is concerned, I think the consensus is reasonable that there is a predictive value for rising mechanical power. Okay, if you look at most of these studies, as you see an increase in the mechanical power, the rates of hospital mortality, 28-day mortality, ventilator-free days, okay, length of hospital stay, everything is adversely affected by increasing amounts of power. There is no question about the fact that as higher power is associated with poorer outcomes. The question that we will always ask is, okay, if that is very true, is there a specific threshold at which we could say that we shouldn't be raising our power? To us, that is going to be very important. You're going to make a decision whether you want to bring it down or whether you want to raise it. We need to know an identifiable threshold where it probably doesn't hurt the patient. And here, unfortunately, the data is extremely obscure. If you look at certain studies, they will show you values that are distinctly different from other studies. I'm not included the one with a greater outlier, which is even saying that 22 joules per minute is probably the best amount of power that you can be giving. And this is very important for us to understand. Why is there something that seems logical, where power is including all the mechanical features that we are concerned about in lung injury, and why is it that it is not able to make an appropriate prediction? And it becomes reasonably obvious to us when we realize that we are not giving the power to lungs that are uniform or normal. Okay, there is a huge amount of variability in the lung, and it is going to be extremely important to recognize that when we are transmitting power to a lung, it is the amount of aeratable lung that is going to be very necessary for us to know. If the lung is totally aeratable, a certain amount of power is not going to damage the lung, in contrast to when it is going to be significantly lower. Okay, and this is pretty well understood. Okay, so under these conditions, okay, we look at the aeratable surface, and there is some amount of evidence from much earlier studies which didn't look at power, but basically showed you that when you have a heterogeneous lung, okay, a lung in which the amount of aeration is significantly lower, that the amount of injury that you create is significantly worse. And that is quite important for us to recognize. The another thing that we probably don't recognize is even normal lungs are heterogeneous, in the sense that we like to believe that the alveoli are uniformly distended, but there are local pressures. So for instance, you can have areas related to deaeration, atelectatic changes, there can be obstructed airways, there can be non-uniform ventilation, there can be issues related to bronchi compressing or vascular structures compressing on the alveoli. So effectively the lung becomes a completely heterogeneous structure. And we know for a fact that when you look at this kind of a model, that when we apply certain amounts of stress on this, there is a maldistribution of this stress. In some areas of the lung, particularly atelectatic or compressed areas, and the areas surrounding that, there can be significant increases in the amount of pressure that you can be delivering. And as a consequence, heterogeneous lung behaves very differently from homogeneous lung. So whenever you're talking about power, you're talking about a global kind of a process, and we don't know what it does to the local areas very, very clearly. Okay, where is the evidence to suggest that when lung injury or when a lung is bad, that the response to power is a little worse? There is some data. This is a very complex paper, a Chinese paper with some artificial intelligence also included in that. I like that because I'm naturally stupid. And I'd like to effectively try to extrapolate something from that, but doesn't matter. What they showed over here is, if you look at the mortality and you look at the mortality related to power, okay, the power in a lung which is minimally injured, that is the mild ARDS in this group that they saw, the effect on mortality is not very significant. You can raise the power, but you don't really hurt the lungs. On the other hand, if you have severe or moderate ARDS, you definitely see a tight relationship between the increase in mortality and the extent of the disease that you have. So clearly that interaction is very important, and they unfortunately were not able to clearly, okay, I think I have, something happened. Okay. So they clearly were saying there is something wrong with this, and can this be sort of an explanation for why deaeration is a very important component? They couldn't do it with this study, but a smaller study seems to imply that quite clearly. That when you look at power and you look at power adjusted to the amount of ventilated tissue or adjusted to the compliance of the lungs, the mortality is clearly better predicted. Or in other words, it is extremely important for us to look at power not just as a single factor, but to look at it as a factor that is going to be applied to a lung, and the variability in the lung is going to make a big difference in terms of how the patient will respond. Now, another issue with power is, as we said, it is not only, it may be easy to calculate, but we take a very simplistic approach about the varying components of power, particularly the application of PEEP. We're always told that PEEP is a very significant component of the power, okay? And if you increase your PEEP, the total amount of power that you're going to be applying to the lung is going to be significantly greater. And as a consequence, we'd always say, be careful, PEEP is going to hurt the power and probably going to hurt the lung. But we know, again, this was a study that Marcelo Brito Passos Amato, who I will repeat over and over again, clearly showed a few years ago, was very controversial in the sense that PEEP will work and be effective in reducing mortality if it is going to be associated with an improvement in lung compliance. And sometimes it does happen. So it is very illogical for us to say that increasing PEEP should increase power. It need not necessarily be very true, and there is some, at least small clinical experiments that seem to suggest that that is very true. That when PEEP is added, the amount of power at, say, particularly when the lung is completely atelectatic, really doesn't change in the adverse direction. You can see it completely flat. And then as you keep increasing it a little further, it probably increases further. And in other words, what we're effectively saying is to include PEEP as a component of power and to put it in as a linear component, something that as it rises, it is going to cause more damage, is not necessarily valid. There is a clear non-linearity to the application of PEEP. So with that as the background, there are other issues also which make power a little difficult for us to completely use. Number one, we completely forget that we are looking at the lung, and the chest wall is not part of the equation. We need to have a way in which we can make a differentiation between the two. I'll talk a little bit about it a little later. And the other thing is we also forget about the exhalational component. There is a very significant exhalational component that can contribute to the power, and whether that manipulation will make a big difference. So broadly what I've said is, if you look at our ability to use power to predict mortality, it is confounded by a large number of variabilities, particularly the extent of the underlying disease and the way in which the relationships of the varying components are to the amount of power that you're giving. So with that in the background, how will we use power? If we start believing that power is bad and we need to reduce the power, how do we handle it? What component of the power should we reduce? Should we reduce tidal volume? Should we reduce respiratory rate? Should we change the PEEP? Okay, these are experiments that are done completely in isolation, where one factor is reduced and you just calculate the power. Okay, and this is not what happens in practice. For instance, if I was to reduce my respiratory rate and say respiratory rate is going to cause a problem with my power, okay, I need to keep my CO2 at a reasonable level. So for isocapnic levels, I probably need to be increasing my tidal volume. And I don't know the relationship between what happens when I increase the tidal volume versus when I decrease the respiratory rate. And as a consequence, unless I keep on trialing it, I wouldn't know if I'm completely able to reduce my power by any specific maneuver. So we really don't know how to even do this. And in that sense, okay, I was a very big skeptic about the use of power, but very recently, okay, my skepticism was sort of given a pat on the back by, of course, Marcello Berto Passos. Okay, if you can repeat this name, it is a very important thing. Okay, if anybody remembers the entire confusing paper, which took a long time but is basically very strongly entrenched in our minds, that is on delta P, okay, or driving pressures, it was Marcello Berto Passos, and he used exactly the same methodology. He used a retrospective analysis of a large number of randomized controlled trials, and he tried to say, we should be looking at mechanical power, and we should be looking at the components of mechanical power to see if they are very useful in predicting your outcomes. And what he saw was very interesting, was the fact that as much as power, you see at the bottom of the graph, is a very good predictor of outcome, the odds ratios are reasonably high, so is respiratory rate and the driving pressure. Or in other words, he's saying that if you look at the respiratory rate and driving pressure, they're probably as important as looking at the power. And he looked at the relationship between the respiratory rate and the driving pressure. As we said, for each 1 centimeter of water change in the driving pressure or a reduction in the driving pressure, he felt that it should be compensated by a respiratory rate that should increase by about 4 breaths, the ratio that they use. And they derived this into a formula, what they call 4 into delta P plus RR. And they said, if this value goes up, that means you're going to have more chances of dying. If that value goes down, it will be very worthwhile. And that is basically what we should focus on. So they used this and put it back into the model. And when they looked at the model again, they looked at the components of power to see which was relevant. Remember, we have 3 components. We have a driving pressure component, which is an elastic dynamic component. We have an elastic static component related to the PEEP that is applied. And we also have a resistive power. And they clearly showed that PEEP was irrelevant, the resistive power was irrelevant. What really mattered is the dynamic power changes alone, which indirectly is exactly what they're saying when you're looking at your respiratory rate times your delta P. Okay, and if you put the model together and you look at the predictive value of combining this parameter, that is the 4 times delta P plus respiratory rate with the power, the value of the power actually declines to almost nothing. So what they're trying to say is the power is expression of the overall energy in, but what is relevant in terms of manipulating the power is going to be your respiratory rate and um, your driving pressures. I think I will skip the talk that I'm going to give on what do you call that, on transpulmonary pressures, primarily because I'm also a skeptic as far as that is concerned. But broadly, I think what we see, we need to understand power is influenced by the settings. Classically, tidal volume, respiratory rate are very strong predictors. Also, on the other side, power is affected by the disease. So, for instance, if you have a greater amount of hypoxia, you're going to give more PEEP. There's no question about it. And that PEEP is potentially going to hurt the power. Likewise, if you have a non-compliant lung, whatever tidal volume is going to translate into a greater delta P, and that probably is going to affect the power too. So we have two factors, ones which are modifiable, ones which are clearly less flexible, and that if we try to make any kind of manipulation on the power, okay, it is very unlikely that you're going to be able to do that very effectively. I don't believe that power is anything other than a grand unified descriptor of the severity of illness, and it is not a manipulatable endpoint. Okay, I'm going to leave it over here because I don't think I'll have the time enough to talk about the rest of it. As the bell has already said, rang. Okay, I just would leave you with this final message. I don't think I would be disappointed if I didn't fully understand the concepts of power, or I can't afford to use the machines that will measure them. Okay, and I naturally don't use them. Okay, but very clearly, I think it is useful for understanding the concepts, but it doesn't necessarily translate into better practice. Thank you for listening, and I apologize that I skipped on a reasonably important second half. Sorry.
Thank you, Dr. RAM RAJ GOPALAN, for taking us through this concept and simplifying the myths. We'll have the question at the end. Can we have the third speaker?